IVF Center in KL. Prior to this, he was the head of reproductive medicine unit in Kuala Lumpur Hospital for nearly 3 years. He completed his IVF training at KK Hospital, Singapore in 2007. Since then, he has been actively involved in providing IVF services and has contributed to the training of specialists and subspecialists in the field. His passion is in management of male infertility and had completed an attachment with Cleveland Clinic, Ohio, US. His other areas of expertise include minimal invasive surgery with special interest in hysteroscopic surgery, robotic surgery, and microsurgical tubal reanastomosis. With this, I'll pass it on to you, Dr. Kanapan.
Thank you, Navdeep. Thank you for the kind introduction. We're very fortunate to have an excellent set of speakers who will be talking to us about different aspects of surgery in IVF itself. Now, I will start off with the first speaker. He is Dr. Vijayavale. He is actually a close colleague of mine. And he's a gynae oncologist working currently at KPJ Klang, and also an advanced gynae laparoscopic surgeon. All right. He did his training in UK, and later on, he went on to do his training in laparoscopic surgery. Currently, he does oncology work in not only in KPJ Klang, but also in other nearby hospitals as a visiting consultant. And he is also a honorary lecturer with the University of Malaya itself. We are privileged to have Dr. Vijayavale speak to us on management of Ismosil. Please come over, Dr. Vijayavale.
Okay, hi, Kana. Thank you very much for the kind introduction. Okay, I'm going to, hang on, I'm going to share my screen now. Okay. Are we clear? Can you see the screen?
Yes, we can.
Okay.
Yes.
So thank you very much for the kind introduction. And of course, first of all, I'd like to thank the members of the committee of the MS Art for having allowed me or giving me this opportunity to speak in this conference of a very rare topic, but a very interesting entity that we are beginning to recognize in this current world of ART. So without further ado, I'd like to go on to the slide. Hang on, some technical issues here now. Okay, I'll just give you a quick overview of the introduction and the history, which I'm going to talk about the Ismosil in epidemiology, description and the importance in subfertility, classification and risk factors for getting an Ismosil, the complications which can happen, diagnosis and treatment, and of course a short case study of about 3 minutes for a case that we had actually done here in Malaysia. Ismosil is nothing but a myometrial defect in the uterine isthmus. It actually just resembles a pouch or a diverticular in the anterior wall of the uterine isthmus. So hence the name Ismosil. Very commonly, it's also known as a uterine niche. We also very commonly know it as a, what we call as a cesarean scar defect. It was first described by Morris. He was actually a South African pathologist in 1995. So what Morris did was he took specimens of about 51 cases post-cesarean surgery, and he attempted to correlate the clinical findings of these symptoms that led to a hysterectomy. And what he found was there was distortion and widening of the lower uterine segment in about 75% of the cases, where he found that there was congested endometrium and polyps at the recesses of the scar itself. So from here, he concluded that there was some abnormalities or anatomical abnormalities that developed in relation to the scar defect. And this was the reason why the patients presented with menorrhagia and of course dysmenorrhea and dyspareunia. So the epidemiology is quite varied if you look at the studies in the literature. They say it goes between 24 to 88%, but generally I think we've got about maybe the upper limits would be about almost 50%. It's also known as the uterine niche, anismocele, uterine diverticulum, caesarean scar defects, and of course, what we commonly see in caesarean scars is the scar dehiscence of these cases. There are various descriptions of anismocele, but 80% of them are actually triangular in shape. About 2% is round, about 4% is oval, and 10% is completely disappeared in the myometrium. Now, what is the importance of an anismocele, one might ask, especially in relation to subfertility? Well, you find that the rates of cesarean section is actually increasing throughout the world, because we've got rates of about, almost 30% in most centers, but in private centers, it can go up to about almost 50%. If you've got one scar, then the rate is about 14% of getting an anismocele. If you've got two previous scars, the rate is about 23%. And if you've got three scars and more, then you've got rates of 45%. Fortunately, in Malaysia, we do not see patients, very many patients with three scars or more. But in places like, say, even in the Middle East and certain countries where they don't allow tubal ligations, then we're going to see more than 50% rates of scar dehiscence, right? And in these pregnancies, there's a very high risk of uterine rupture and placental adhesions. As far as subfertility is concerned, how does anismocele cause subfertility is in two folds, where on the blue section, you will find there's inhibition of sperm flow. What actually happens is you've got endocervicitis, which happens in the scar recesses. And because of this, you have persistent blood in the cervical canal. You've got mucosal changes which happen in the scar recesses, and therefore this gives rise to inhibition of the sperm flow. As far as embryo implantation is concerned, there's a continuous reflux of blood which happens in the reservoir of the scar recesses, leading to chronic inflammation, endometritis, and of course because of this, there's inhibition of embryo implantation, and this leads to subfertility. Right. What are the risk factors for the formation of anismocele? Well, you've got the non-modifiable risk factors, where you've got patients with multiple scars. Obviously, if you've got multiple scars, then you've got repeated trauma to the wound, and this can impair the healing process. If you've got retroflex uterus, there's adhesion formation to the anterior abdominal wall, and this causes counteracting forces on the uterine wound, so it leads to impaired wound healing for these caesarean scars. You've got labor-related risk factors, where you have got labor of long hours, more than 5 to 8 hours, when you've got cervical dilatation more than 5 centimeters, and in some cases where you do a caesarean section on lower stations, so you tend to do a low incision on the cervix, and you do repair sometimes, you take in the mucous gland, and this also leads to impaired healing process. Surgical techniques where we have got incision closest to the internal cervical os can also contribute to the anismocele. You've got suturing techniques can also contribute to the anismocele, where you've got improper closure of the caesarean scars, or we've got non-closure of the deeper layers. One layer closures used to be common those days, but nowadays we don't do this. And sometimes when we include the decidua in the sutures, this can also lead to improper healing. So anismocele has got various types of classification, but what I want to impress upon you all is that for management purposes, what is important is actually the residual myometrial thickness, where you've got large defects where the residual myometrial thickness is less than 3 millimeters. I will be explaining what the residual myometrial thickness is. In smaller defects, you've got residual myometrial thickness of more than 3 millimeters, right? So basically, this is what you have to remember. How would you measure? Very easily, it's done in an office setting where you use a transvaginal scan to measure the sagittal plane. The bladder must be full, of course. The shape of the caesarean scar is defined. The depth of the caesarean scar is also measured. The length of the caesarean scar and the internal cervical os is measured for purposes of if you want to do surgery for such patients, the thickness of the myometrium is measured at the peak of the scar, right? So you can do all this with the transvaginal scans, right? The parameters that would just be very, very important would be the scar width, where you want to measure the length of the widest gap along the psoas-isthmic canal. You want to measure the depth or the scar depth, which is actually the vertical distance between the base and the apex of the defect. And then you want to measure the residual myometrial thickness, or what is marked here as T, right? So you can do that with a transvaginal scan like such, right? You can find the scar width, you can find the scar depth, and the residual myometrial thickness is then measured, okay? So this is with a transvaginal scan. If you do have caesarean scar defect, then obviously you will have also sometimes abnormal placentation. You can have placenta previa, you can have accreta, increta, percretas, because your residual myometrial thickness can become less than 3 millimeters. You can have scar descent, which is very, very commonly described. When you do two caesarean scars and above, you find that, you know, some of the doctors come and say, oh my God, it's a very thinned out myometrium. You can have uterine ruptures, obviously, and caesarean scar ectopic pregnancies. These ectopic pregnancies usually do not happen very, very commonly in the caesarean scar defect because of the inflammation, it actually goes on, actually prevents pregnancies in the recesses of the scar defect. Gynecological complications is what is important for us, because most of our patients come in with abnormal uterine bleeding, where you've got about 30 to 80% of them who present, and most of them present with post-menstrual spotting. Usually it's about 2 to 12 days after their menstruation period, right? And it's dependent on the size of the defect. A lot of them obviously present with dysmenorrhea and pelvic pain as well, because of the inflammation which goes on. There's fibrosis, which can actually contribute to the dysmenorrhea, and this anatomic disruption of the lower segment as well. Post-menstrual bleeding, again, it depends on the defect of the scar. You can have about 60 to 80% of them. Our patient actually presented with post-menstrual spotting, and that is how we picked up the caesarean scar defect. And of course, secondary infertility, which happens in about 50 to 75% of the cases. How to diagnose an isthmosil? Well, you've got the gold standards of diagnosis, which is actually just a simple basic transvaginal scan, and also the MRI of the pelvis. This is very easy to do. You're actually very easy for you to do a transvaginal scan in an office setting. It's much, much cheaper than an MRI, and all you need to look out for is image of an anechoic area of a triangular shape in the lower part of the uterus. If you have access to an MRI, then of course it shows the defect very clearly. You're able to document and also measure the defect. It sets the level and the limits of the defect as well. But unfortunately, it was only first described in 2014 by an MRI. So not very many people are aware of describing these defects in the sense for a routine MRI. Then you have the saline-infused sonography, which is actually quite easily done as well. HSG is not very, very useful, but it can be used. You've got hysteroscopy, where you can use that in an office hysteroscopy setting. Actually provides a clear visualization, but in this case, obviously, you can't measure the residual myometrial thickness. Coming to treatment, you can obviously divide this into patients who are symptomatic and asymptomatic. And you only would want to treat patients who are symptomatic, but expectant management is possible when you have a residual myometrial thickness of more than 3 millimeters or in small isthmosils. You can try medical treatment. People have tried OCPs and Mirena as well. The OCPs actually are only good in reducing bleeding disorders, but not very good in actually treating their post-menstrual symptoms. So the outcome is usually very poor. Mirena obviously has got no benefits, not very much, but you can try it for patients who do not desire pregnancy. So coming to the types of treatment, you can have the conservative treatment, which is, like I said, you can do an expectant management for these patients. You can try oral contraceptive pills. You can try intrauterine Mirena insertion. And of course, you've got the surgical treatment, which is actually the hysteroscopy, the vaginal method of treatment, which is not very easy. You can do both laparoscopic and vaginal methods of treatment. You can do laparoscopic treatment, which is what I'm going to demonstrate later. You can do laparotomy, obviously, and some do robotic. You've got access to robotic surgery. Uterine artery embolization, you can try. It just reduces the amount of blood supply to that particular area, but not very useful as such. So in the surgical treatment of isthmoceles, this should be offered to symptomatic women who want to preserve the uterus, and possibly to asymptomatic women who are planning to have future pregnancy. The type of surgical treatment, you can do laparoscopy, you can do vaginal surgery, or you can do hysteroscopy. But until now, there's no treatment which has been proved to be superior one or over the other. So these options should be actually very, very carefully discussed with the patient, right? In the surgical treatment, the surgical approach should be determined by the patient's plan for fertility and by the measurement of the niche thickness. Like I said earlier in my slides, a hysteroscopic resection you can actually offer to these patients when the residual myometrial thickness is more than 3 millimeters. Then it is preferred if there's no desire for pregnancy. It does play a role in selected cases. It's got a high rate of success. One would want to use a bipolar resectoscope, where it's actually a 16 French resectoscope, where you've got better mobility than a 26 French resectoscope. You'd want to do a 360 resection, so you don't end up with the cervical stenosis post hysteroscopic resection. But you have to be careful where you've got residual myometrial thickness of less than 3 millimeters, because sometimes you do run into a risk of bladder or uterine perforation. The largest study was done by Guvini back in 2011, where he had 41 patients and he had about 100% success pregnancy rates post resection of this isthmocele. The laparoscopic approach is quite new. It was first described only in 2003. It's actually a preferred method of treatment. Because when you do a laparoscopic resection, then it is optimal for patients because we can actually visualize this defect very, very clearly, and you're able to approximate this myometrium using a 2-layer closure. So it's actually very safe for patients who want to embark on a pregnancy. If you've got a residual myometrial thickness of less than 3 millimeters, then obviously you can strengthen the myometrial wall, and it reduces the risk of uterine rupture. The largest study which was done was actually by Jacques Donnet back in Belgium, and I think everybody knows who Jacques Donnet is. He had a total of 38 patients, and among them 18 patients were consulted for actually infertility alone or infertility associated with pain or bleeding. Out of this, 44% of them became pregnant, and all of them delivered healthy babies by cesarean section at about 30 to 39 weeks, right? So what he proposed was, in symptomatic women with a residual myometrial thickness of less than 3 millimeters who want to conceive, then laparoscopic repair should be proposed, and is actually the best method of treatment. Now, the outcome of a surgical repair is very good, because we find that in meta-analysis, hysteroscopy and laparoscopy, you've got a success rate of about 80 to 90%, right? So in conclusion, an isthmocele should be included in the differential diagnosis of abnormal uterine bleeding. Only symptomatic isthmocele should be treated. TVS is a very accurate method, it's cheap, it's easy to use. Hysteroscopic treatment is also seems to be very effective. And the correction of the defect is associated with improvements of at least in their symptoms at least. With respect to infertility, the surgical correction restores fertility in high percentages, right? So I'd like to go on to the case report, just a short 3-minute report. We had a 31-year-old lady who was a para 1 who had a previous car about 12 years ago. It was uneventful. She gave a history of a cystectomy about 10 years ago. And then she came to see me 5 years ago in KPJ Klang for serous cyst adenoma. I did it for her laparoscopically. She presented with subfertility. She went on to do an IUI and then IVF. After doing the IVF, it just failed, and then she was referred back again because the referring physician found out that she had an isthmus. She was referred back for laparoscopic repair. We did the repair. She went back again for the IVF, and now she's currently at 32 weeks of gestation and uneventful pregnancy so far. So we've got this documented via a sonographic picture, a transvaginal scan, which was done in my clinic. You can find the uterine niche over there. Where the arrow is placed, and we've got a an MRI of the pictures. You've got a 3.5 millimeters of residual myometrial thickness. Obviously, in this case, because she was going on for a pregnancy, we decided to do a laparoscopic repair to strengthen the myometrium, right? And I'll just show you very quickly in my video what is done. We actually started off with a hysteroscopy. As soon as you enter, if you go to the anterior part, you can find the defect in the roof of the isthmus itself. You can find, and then you evaluate the cavity, okay? And then during laparoscopy, you can actually identify the niche by using the hysteroscopy as well. You try and resect the bladder. You've got to be very careful here where you resect the bladder, because obviously sometimes you end up with dense adhesions. Try not to go too lateral, because you might end up with hitting the uterine artery, then you have a lot of problems trying to secure that bleeding, right? So once you have resected the bladder away, this patient also had a retroverted uterus, so we had to free off the adhesions, and it became a bit more mobile after that. You can actually identify the niche using the hysteroscopy. You can dim the lights, and you'll find a very thin layer of myometrium left over. Okay, using this, you can use I used the monopolar hook to resect the scar, right? You got to be very careful so you don't hit the light of the hysteroscope. Okay, don't go too lateral as well. And once you find the reservoir of mucus, then that's where the defect is, right? So I trimmed the scar defect because some of them present with a bit of adenomyosis, so that healing becomes better after the repair. And then we did a full thickness repair, interrupted sutures. In this case, I used non-absorbable sutures, but I think you can actually use vicryl sutures, absorbable sutures. The first layer, you try and repair it using interrupted sutures, and the second layer, you can use continuous sutures just to cover up the first layer. So using vicryl, I used 1O in this layer, where the second layer is used to bury the first layer, just like a cesarean scar defect. Okay, you can use it in a continuous manner. Okay, just to sort of bury the first layer, or rather imbricate the first layer. And once you've got that, then you're quite sure that you've actually strengthened the myometrial closure, right? And obviously you want to try and prevent more and more adhesions as well. So make sure that your field is dry and not much of blood and blood clots inside the cavity. You want to give it a good washout, and I actually applied a bit of gel as well before closing the bladder flap. The bladder flap is obviously closed because you do not want to have adhesions in this lady. So the closure of peritoneum was done, and sent her back for IVF, and very lucky she was with the first IVF. After that, she got pregnant. She's, like I said, she's 32 weeks of gestation now. So post repair, you can actually find the defect now has been repaired, and you can see, I mean, it's not very easy, very obvious, but you can find the suture site there. When the transvaginal scan was done in my clinic, then you can actually find the white of the threads in the area of niche repair. So this actually goes on for maybe about a month, and after that, after about, I think, 3 months, you can actually go back for an IVF. So yes, so that's the repair that we did, and we've got a successful pregnancy out of this. We've done one more case after that, but so far no news so far from my referring physician. Well, hopefully he comes back with good news post the second niche repair. So I thank you for your attention, and I'd like to open the floor if there are any question and answers.
Thank you very much, Dr. Vijay. Excellent lecture. Excellent lecture. Made it very simple. Wonderful video and wonderful surgery. Very happy to hear the patient is pregnant currently. Now, a few questions. Okay. One is that when is the best time to scan for this defect in the menstrual cycle?
Well, the best time is actually during the proliferative phase, because this when you get a thin layer, just immediately after your menstruation, you get a thin layer of the endometrium. And if they actually have got a fluid collection in the cesarean scar defect, then this is very obviously seen on a a transvaginal scan. That would be this one, and it works out well for the infertility specialist, because you obviously would want to see the patient at day 6 to day 8 of cycles, so that you can start your treatment. So this is the best time to pick up such cases.
There's a question from the audience. If the patient has got bleeding due to the niche as well as fibroid adenomyosis and others, would HIFU help?
Well, HIFU is something very new. I do not think that HIFU would very help, especially in this area of a cesarean scar defect, because HIFU would probably help where you've got larger amounts of adenomyosis, obviously like an adenomyoma and things like that, where you've got adenomyosis in just at the cesarean scar defect itself. I don't think there's any studies done as far as I know, but you can surgical correction would probably be better, because you can that improves the inflammation, because HIFU does not give you resection of the adenomyotic or fibrotic segment of the scar. So no study so far as HIFU is concerned, as far as repair of cesarean scar defect is concerned.
Now, you talked about laparoscopy. You showed us a video. What would you do in a hysteroscopy procedure?
Okay, that's very interesting. A hysteroscopic repair can be done where you want to resect the anterior and posterior edges of the scar defect. Some describe that after you have dissected the posterior wall, then you can actually release the collection of mucus in the reservoir of the scar recess. And once you've released that, they actually say you also want to resect the posterior wall so that you don't end up with cervical stenosis. So this is very easily done using a 16 French hysteroscopy, like I mentioned earlier, because you've got a bit more versatility as far as turning your scopes around and resection. And if you use a bipolar resectoscope, then obviously your bleeding will be much less and things like that.
Okay. And you mentioned it's not desirable when you're going for pregnancy? Yeah.
Well, because the hysteroscopy doesn't strengthen the myometrial scar defect. So that's why you want to only use the hysteroscopy when you have a small isthmosil. If you want to have a patient who is going for a pregnancy, then obviously you want to strengthen the myometrial defect so that she can actually sustain the pregnancy as well as carry on this pregnancy to term. So the only way would be to either cut open the scar, or either laparoscopic or laparotomy or robotic surgery. The hysteroscopy works very well for patients whom you just want to treat their symptoms rather than for patients who actually want to go for the pregnancies.
I think you had answered this question, but I just highlight it again. I think one of the speakers said whether during Caesar one layer closure or 2-layer closure. I think you clearly mentioned that. Yeah.
It's actually very interesting, because they've done studies on this, and they found that the 1-layer closure actually gives rise to more cases of the scar defects as well as larger defects. And also there are also questions of whether you want to do interlocking sutures in the first layer compared to interrupted sutures. Some have suggested that interrupted sutures, obviously, you do not have much of tissue ischemia during the closure, so therefore you don't have a dehiscence. I think this is the same principle as a vault closure as well. But like I said, this is all very, very new to us. We do not have enough powers or the numbers to conduct robust studies and also make recommendations. These are all just observational studies as to date.
Fine. With that, I think we come to an end. Thank you for an excellent lecture. Thank you for a very nice video. Good to have you on board. Thank you on behalf of EMSA. Bye.
Thank you. Thank you. Thank you very much for having me.
We are privileged now to go on to the next speaker. He is no other than Dr. Silva. And Dr. Silva, I think, is very well known. Okay, he's very well known, but it's my duty to go through his CV, all right, to give you an introduction. He is the senior ONG consultant, and he is a subspecialist in reproductive medicine at Makota Medical Center. He does everything, okay? You name it, he does it, okay? And he's an excellent laparoscopic surgeon, hysteroscopy, and he does significant IVF work in Malacca itself. He's done more than 8,000 cases. He's published a book, which all of us have. And recently he started the ultrasound-based HIFU, okay, with very good success outcomes. Without further ado, I call upon Dr. Silva to speak to us on improving pregnancy rates with the use of additional contents, yeah, or anti-adhesives. Dr. Silva.
Thank you, Kana. Let me share my screen. Okay, good morning, everyone. Thank you for allowing me to give this lecture, and thank you, Kana, for the kind introduction. My topic is on improving pregnancy rates with the use of anti-adhesions, and I'm going to introduce you all to a new product called For-Dry-Feel. Now, this is a sponsored talk. This is my disclosure. Now, For-Dry-Feel is actually a powder consisting of sterile hydrophilic microparticles. It is manufactured from highly purified polysaccharide in a complex process. Now, this is how it looks. It comes in a pump-like structure. We will show you how it works. It's patented product by Plantech Medical Germany. Now, For-Dry-Feel is the only CE certified product indicated for hemostasis and adhesion prevention. And there are more than 10,000 surgeries performed using For-Dry-Feel successfully. Its proven efficacy and well documented. It contains no component whatsoever of human or animal origins. There's no worry about halal factors. It's proven safe. And For-Dry-Feel remains in the body for 5 to 7 days, after which the body's own amylase will digest and absorb it. So today I'm going to introduce this, and also at the end I will just give a case of my experience using it. Now, first question is it safe? Now, this is the study that shows that For-Dry-Feel is not cytotoxic and does not enhance viability of tumor cell lines. High dose of Dry-Feel of 1.05 grams per kilogram body weight is well tolerated and reduces weight loss in animals with peritoneal injury. Its biocompatibility for Dry-Feel can be rated as being excellent. So it is a very safe product, and it's been used for over 100,000 cases so far. Now, if you look at it, it has actually got two benefits, which is adhesion prevention and hemostasis. And that's the reason why I was excited about this product when it was introduced to me some time early this year. Now, first, let me look at the hemostasis effect. Now, the mode of action is that it has got a hydrophilic microparticles extract the water from the blood, thereby concentrating clotting factors and platelet, and causes acceleration of the coagulation cascade. Now, this is how it works. You place the particle onto the area that is bleeding, and the particles will then absorb the water from the blood of the blood into it, and it will cause concentration of the coagulating factors causing blood clotting. And once that happens, within seconds, there will be blood clots formation. And this is an animation showing it. So this is a bleeding area. The first thing to do is actually to try and remove as much of this blood as possible. And then you apply this powder onto that area. And once it's placed, you can actually place a gauze to apply some compression. And what happens is that these particles will then absorb all the bloods. And because the blood is absorbed, it concentrates the area and promotes fibrin formation, and then causes a clot to be formed. And it works very fast with this, in this way. Now, this study shows the purpose of this study here that I'm showing is a study to determine the effects of this for dry fill on viscoelastic coagulation parameters as assessed by rotation thromboelastometry. Now, what we want to know is that if you have dilution of blood, which can happen when there is bleeding, anesthetists will then place in a lot of hemodiluents and the blood becomes dilute. And will this work? And this study shows that the application of for dry fill significantly increases the speed of coagulation and clot firmness, even under conditions of dilutional coagulopathy. With a normal dose of for dry fill, the firmness of clot is 50%. Diluted blood is comparable to that of native coagulum and might be capable to seal microvascular bleeding areas, indicating that even in diluted blood, it works well. Now, I'll show you this video. This is an animal model, and we have made a hole in the liver, and the for dry fill powder is then placed on top of it, apply pressure with a gauze, and then place a little bit of saline on top of it. That's how it's done, and it prevents bleeding. And here is another lesion. There's the liver, part of the liver is being cut away, and then a for dry fill is then placed on top of it. The powder is placed. There is some blood here, and that blood is then applied pressure on, and then you place some fluid and a gel forms, and then it causes hemostasis. And this here, they are cutting the heart, making a hole in the heart and cutting a little bit of tissue of the heart. And in a similar manner, placing the powder will then cause hemostasis in this area. So you can see they can place the powder on top of it, apply some pressure, put some water on top of it, and then a gel is formed and the bleeding stops. So this is how it works. So application notes for hemostasis is that first you clean the blood as much as you can, keep it dry, and then place the powder on top of it. And if necessary, put a gauze on top of it to apply pressure, and then the hemostasis will be achieved. So this is how it works for hemostasis. So the advantages of for dry fill for hemostasis is that it can be used on a large area when there's diffuse bleeding. And for us, laparoscopic surgeons, this is exciting because this applies to areas of deep endometriosis and deep infiltrative endometriosis where a lot of excision is done. We can apply it on a large area, and even in 50% hemodilution, normal physical properties of coagulum occurs. The hematoma is a clot that degrades faster than the native coagulum, so significantly reduces hematoma formation. And there's no animal or human component, so it's very safe. So these are the advantages of for dry fill for hemostasis. But what I'm more interested in is adhesion prevention. As a reproductive surgeon, I do a lot of surgery for patients with endometriosis. And we want to look for a product that not only causes hemostasis, but also prevents and causes adhesion prevention. Now, we all know about adhesions. We know that it's a major problem. It causes 60 to 67 to 97% of post-op, and even after adhesiolysis, there's 86 to 97% reoccurs, and this is especially so in small bowel. And there's a lot of problem with adhesions post-operatively. But for us as reproductive surgeons, what we are most worried about is when we do surgery around the ovaries, in the pouch of Douglas, and around the fallopian tube. We are worried that the tubes will get stuck and the patient will not conceive. So we are looking for products that will prevent this from happening. Now, this is how for dry fill works as a prevention of adhesions. It works in two modalities. Action number one is that it causes rapid hemostasis, less exudation, and less fibrin deposition. And action number two is that it forms a gel, a physical barrier that prevents tooth surface from adhesions by preventing formation of fibrin bridges. So there are three ways in which we can apply for dry fill. In open procedures, you can use this and just place it on top of the area where it's bleeding and then apply saline. You can actually mix it. 1 gram can be mixed with 10 mils of physiological saline to form a gel, and then you can apply the gel. I will show you some videos how this is done. And thirdly, this is our favorite part, is you can have a laparoscopic applicator where you can apply on top of the area and then drip some saline to turn it into form a gel. Now, this is the first application where there is a large area and laparoscopically that has been done, and you can apply this for dry fill through the laparoscope on these areas, on this large area. And after that, you can then drip some saline on top of it, and this saline will then mix this powder to form a gel. And this is what that is exciting for me. Current available anti-adhesions does not allow us to do this because we can't see the gel formation on that area where we apply the product. And so here you can actually see the gel and on a white area in which the powder has been applied. Now, this is how it is mixed up extracorporeally. If you think that you cannot apply the powder, then you can actually change the powder into a gel. As I told you, 1 gram is equal, it should be added to 10 mils of water. Here, all this powder, I think there are three bottles of product here. And then you add the water to it, and then you can turn it into a gel. And then this gel can then be applied either in open surgery or laparoscopic surgery. But studies have shown that if you use the powder and drizzle water on top of it, it prevents adhesions far better than if you do it this way in terms of a gel. So I would advise you all to use the powder in the laparoscopic form and then apply some water to get better anti-adhesions. So it's quoted as more about 95% in that way than if you use a gel form, which is about 85%. Now, here is a patient who has got a laparotomy and adhesiolysis. And when you have done an adhesiolysis, then you can wash, and then you can actually apply this gel that I showed you earlier. So you can mix the powder to form a gel, and then you can apply the gel to all these areas where you have done the adhesiolysis. And in this particular case, you can see that the surgeon is drizzling the mixed gel all along the areas where the adhesiolysis is done, because here, if you put the powder, it will probably not get to all the areas. So using the gel will be a better option here. But after placing this gel, we are always worried that the omentum and even the intestines may get stuck to the skin. So to prevent that, what they are doing is that they're placing the omentum on top of the intestines, and then they place the powder on the omentum to prevent the omentum from getting stuck to the abdominal wall. I mean, we all see this when we do laparotomy and when we do laparoscopy in a patient who have previous laparotomy, the omentum will always be adherent. Even the intestines will be adherent to the abdominal wall. So this is the way in which it is done. You apply the powder on top of this omentum and then drizzle some water on it so that it turns into a gel. And once this is done, then you can suture the abdominal wall. So you can see that you can drizzle the abdomen, and then you can close the abdominal wall. Now, the next question is, how does it work in gynecological laparoscopy? I think there are very, very few studies that have actually looked at a product and done a second look laparoscopy to see whether the product works. And this is one of such studies. The use of modified polysaccharide for dry field adhesion prevention and hemostasis in gynecological surgery, a 2-center observational study by second look laparoscopy. So the conclusion is that with the use of modified for dry field, an immediate hemostatic effect could be observed in persisting oozing after reaction of endometriosis, confirming its hemostatic capability. So modified polysaccharide for dry field is not only effective in diffuse bleeding. In this cohort with extensive surgery for various gynecological pathologies, for dry field showed effective adhesion prevention. Its use as a premixed gel is a convenient variant for the treatment of large peritoneal wound. Now I'll show this video that shows one of these cases. This is a patient who underwent surgery, and then they did a second look laparoscopy. Here you can see the typical endometriosis case. Here, this surgeon has done an ovariopraxy, and he has released this ovary from the pelvis. There's a lot of adhesiolysis done in the pouch of Douglas, and this is something that we see all the time when we operate. Now, how to prevent adhesion in this kind of cases? So here, this powder is then placed on the areas that have been operated. And then you can see that the powder is then sprayed to all these areas. This is something that I always find it difficult to do with just gel. If you can put the powder on that area and then place some saline on top of it, you can see that exactly where the gel has formed. And this is the beauty about for dry field. And in this particular case, this surgeon actually did a second look laparoscopy, and it's actually looking absolutely fabulous. And you can see that 8 weeks later, when they did the second look laparoscopy, the pelvis looks very clean. And you can see that there's no adhesions at all here, and there's no adhesions in the ovarian fossa. And if we can achieve this, then we don't need IVF. The patient is going to get pregnant on our own. And that's probably what we reproductive surgeons aim for when we do surgery for, when we do pelvic surgery for pelvic pathologies. Here it can be also used for cesarean section. Here you can see this video, how to prevent adhesions in cesarean sections. You can remove the cap. And in this cesarean section, I was told that they can use only 3 grams is sufficient. So clean the area and then apply the powder on top of the scar. And you can see here the powder is being applied on the scar, and after that it is then drizzled. Let me fast forward this. It's then drizzled with water. And you can see you can drizzle it with water, and this can be one way of preventing adhesions. This may not take up in Malaysia, but there are some patients who ask for anti-adhesions, and this may be another option for patients who want anti-adhesions after a cesarean section. Okay, the next question is, how does it compare to hyaluronic acid? You know that there are many hyaluronic acid-based anti-adhesions available in the country. And many of the hyaluronic acid are not used with what we call as hemostatic agent. They are only anti-adhesion agents. But unmodified hyaluronic acid is subjected to rapid degeneration and a site of operation within hours. So it is not useful to use hyaluronic acid alone. But if you use it with a hemostatic agent, like for example, this Medicurtin, they have this HES added to it, and it is shown that this HES actually may increase the prothrombin time. And there is also no RCTs to show that these particular products, hyaluronic acid based products, actually causes prevention of adhesions. Now, I've also come across many products similar to this before. For example, Arista, Hemoser, people have come and showed me that you can use these powders to prevent, to actually cause hemostasis. These are all very good hemostatic agents, but they are not also anti-adhesive properties. And that's the reason why I'm very excited about 4-Dry-Fill, because it is probably the only product which is in this powder form that not only causes hemostasis, but also causes anti-adhesion. So it is now available in several products. This is the product, and it is available. There is a attachment for laparoscopy. It comes with 1 gram, 3 gram, 5 gram, and 9 gram. I've been using these two products, 5 gram and 9 gram, in my practice just the last few months. And I'll share with you all one case that I've done recently. Actually, this is my second case using this product from the supplier, the sample from the supplier. This patient saw me in October 2020. She's a 30-year-old lady, married in February 2018. She had a laparotomy and bilateral cystectomy for stage 4 endometriosis done in February 2015. And she was given generation analog for 6 months. After that, in 2019, when she did a HSG, she had a left hydrocephalus. Ultrasound down showed a bulky adenomyotic uterus. There were 2 endometriomas in the right ovary, small ones, and a left endometrioma measuring 2.28 times 1.19 centimeters. Her AMH was 1.96. And this is how it looked. This is the uterus, retroverted uterus, with these small endometriomas. So I told her that if I go in, it is not going to be very easy surgery, and then I'm not sure about her pregnancy rate. So I actually advised her to undergo IVF first before I have to do a laparoscopy. I had to do laparoscopy because she had hydrocephalus. I need to probably remove or release that tube. So she underwent an IVF in January this year. We froze 6 embryos. In March 2021, I did a laparoscopic surgery, and this was a short video of the laparoscopic surgery. As usual, after a laparotomy, there will be a lot of adhesions, And after performing the omental adhesiolysis, I released all this bowel that was adherent to the uterus, and the uterus was also stuck. There was a lot of adhesions between the uterus and the intestines. And this is the left ovary. There were sutures seen. These are non-absorbable sutures. This is the right fallopian tube that was stuck. And this is what we want to prevent. We don't want this kind of adhesions, which is not going to help her to get pregnant. And the tubes were released. And so all the adhesiolysis were performed. And here the ovary was released from these intestines. Many people are still very keen on using non-absorbable sutures. I've given up using non-absorbable sutures for adhesiolysis. I usually use absorbable sutures nowadays. And here is a small endometrioma, and that was released. And of course, the rectum was stuck to the uterus, and this is usually the most difficult part of the surgery. In my practice, I will completely release the rectum from the uterus and then excise all the disease in the pouch of Douglas. And this is what I'm trying to do now. I've released the whole rectum from the uterus, and there is a large endometriotic and adenomyotic nodule here, and that was excised. So this patient, the endometriotic nodule, which is the deep infiltrative endometriosis, was stuck to the vagina. So a lot of excisions of this disease was done. And there was also a nodule in the vagina of the uterus, in the vagina as well. So here, as you see, I can see that I had to actually go into the vagina to remove all this deep infiltrative endometriosis. Here I've entered the vagina and then excised this nodule. So there you see I'm in the vagina, and then the nodule is then excised. So once this nodule is excised, the vagina was repaired. So here I've already removed almost probably 95% of the disease in the pelvis. I also performed the cystectomy for this patient. The cyst was not very big, and cystectomy was done, and the ovary was also repaired. So after doing such nice surgery, what we are worried about is these things all going to get stuck. So here I'm using the 4-dry fill to apply it on all these areas, these raw areas that, and I can see that this powder actually sits in the proper position. Although this is only the second case I was using, I'm still learning how to use this. There's some learning curve to apply this nodule. And then when you apply some water, you know that the gel is actually on that area where you applied the powder. So this is at the end of the surgery. So what I did subsequently is to do the embryo transfer. Frozen embryo transfer was done on the July 2021. 2 embryos were transferred. She's now pregnant with twin pregnancy. Now, I'm not saying that she got pregnant because of 4-dry fill. Many factors are involved. Firstly, the IVF and the frozen embryo transfer might have just got her pregnant. But what I'm hoping for is that my surgery and also the application of the anti-adhesion will cause less adhesions, and the patient will conceive a second pregnancy without any surgery. So that is my hope. So in conclusion, 4-dry fill offers immediate hemostasis. It allows less fibrin formation, which is a precursor of fibrinous connection between scar tissues. 4-dry fill hydrophilic microparticles, along with physiological saline solution, form a viscous gels within seconds, and you can see it and you can know where exactly the gel is. This viscous gel becomes a physical barrier on a scar tissue and prevents formation of fibrinous tissues between the scar tissue and other nearby organs. The modified polysaccharide 4-dry fill remains in the body for 5 to 7 days, which is important, where mesothelial healing takes place, and so that the two surfaces do not get stuck to each other. So after 7 days of the body's amylase digests 4-dry fill and will be absorbed. 4-dry fill is very safe and biocompatible, up to 1.05 gram per kilogram body weight, and is well tolerated. Thank you. I think I'm over 22 minutes. Back to you, Kanna.
Yes, thank you, Dr. Salva, for a very interesting lecture. Wonderful, wonderful videos as usual. You did an extensive surgery and remarkable. Now, 2 questions. One is that in regards to the Caesar, you had mentioned it can be used for cesarean section. One of the speakers was saying that they're facing adhesions more at the upper part of the uterus compared to the lower part. So how do you apply this adhesive barrier?
I don't understand by the upper part of the uterus. I think the most adhesions occur between the cesarean cesarean, where you do the Caesar and the abdominal wall. I think that is the addition. Whether how it happens above or below, we're not sure. But the current practice is that you don't do peritonization. I think that is what everybody is doing. I'm an old school of thought. I trained in the 90s and I always peritonize my patients. I think that may be a problem. You have a large raw area, it gets stuck. Probably that's one of the reasons. But using anti-adhesions will definitely benefit patients like this. Where it is going to get stuck, I'm quite sure it's because the raw area just moves up and gets stuck on the upper area. There's no other place that is raw enough for the adhesions to occur. That's my thing. That's my thought.
Second question is, you were using saline on top of the powder. What about the body fluid itself? Would that be, instead of you applying all this, would you just leave the body fluid take over the function?
This is a good question. I don't think it will work because the body fluid will have fibrin and other structures, and that are things that we need to remove from the patient. So it's actually good to remove as much of the blood and apply the gel, and then on top of the gel put the saline together so that the saline can be absorbed by the microbubbles and then form the gel form. So it doesn't work with body fluids. It only works with saline applying after application of the powder.
Final question, what's the cost?
Yeah, you have to ask the distributors. I don't know whether they'll allow me to say this, but it ranges between 500 ringgit to 700 ringgit for the higher dose, which is 5 gram and 7 gram. These are the ones that I'm interested in. I ordered 5 gram and 7 grams because the 7 grams and 5 grams, the difference is probably about 200 ringgit. And you have a liberty of actually applying to a lot of areas. So that is the cost price to the hospital. Of course, when it comes to you, it might be much higher. So that is the range that we are talking about. And I don't know whether I'm allowed to say that, but I'm saying it on behalf of the distributors.
Thank you so much. Thank you, Dr. Selva, for a wonderful lecture. It was nice having you today morning.
Okay, thank you, Kana. Bye.
Now we go on to the next lecture. This is a topic on fertility preservation techniques in endometriosis surgery. We are fortunate to have Dr. Muhammad Faisal bin Ahmad. He is a clinical specialist and senior lecturer at HUKM. He did his master's in UKM and he went on to do his subspecialty training in St. Mariana School of Medicine, University, Kawasaki, Japan, where he did his reproductive medicine. And subsequent to that, he has gone on further to do training in endometriosis infertility and as well as oncofertility. So he has he talks about oocyte and embryo cryopreservation in good prognosis cancer cervical patients. He has done quite extensive studies, and currently he is the board member of the Malaysian representative of the Asian Society of Fertility Preservation, as well as the vice president of Malaysian Society of Fertility Preservation. We have Dr. Muhammad Faisal. Welcome.
Thank you very much, Dr. Kanapan, for the very kind introduction. Assalamualaikum and good morning, everyone. So I would like to share my slide first. Can you guys see my slide?
Yes.
Okay. Thank you very much. So I would like to talk today regarding this fertility preservation technique in endometriosis surgery. I think the best person to talk is actually Dr. Selva, but I'm fortunate to give this opportunity to share with you what is the current advisable method for the endometriosis patient. So endometriosis and reproductive outcome, as we know that 1 in 10 of women is having risk of endometriosis, and it's one of the contributor factor that declining birth rates among Malaysian women. About 25 to 30% of our women has difficulty in conceive and exhibit sign and symptom endometriosis, and 30 to 50% of them actually have the endometriosis experience of infertility. So as we know, as we go along as reproductive specialists, we know that this endometriosis is one of the biggest challenge if you do an IVF or IUI or fertility treatment, as it's actually harbors a lot of inflammation and also mediator that reduce the success rate of our fertilization rate, as well as oocyte quality, embryo quality, and also implantation failure. Therefore, the endometriosis treatment actually is stuck at the area of that not yet possible to complete resolution, but the therapy is essentially for the main three objective. One and foremost, to preserve and improve the fertility, to reduce the pain, and also we want to delay the recurrence as long as possible. So endometriosis treatment rate associated infertility have been investigated with medical and surgical therapeutic modalities, individual or in combination. In the cases of moderate and severe endometriosis, usually the medical and surgical approach remain a gold standard. But the most important thing that we need to know is in endometriosis, the most important thing that we always see in our daily practice is endometrioma, and this excessive surgery for the endometrioma can lead to the reduction of normal ovarian tissue, lead to the low MH associated with much higher recurrence, as well as reduced ovarian reserve. Actually, there's a lot of study have been established an impact of endometrioma and laparoscopic technique in reducing the serum anti-murine hormone. So in the interest of the time, I would like to share this one particular study. This study was done in China, whereby the serum AMH had been proposed as marker of ovarian reserve. And the aim of the study is to evaluate the impact of endometrioma and laparoscopic cystectomy on ovarian reserve measured by AMH level. So they did this study in 1,642 patients and recruit for retrospective analysis, which a control group patient without endometrioma, the second group endometrioma group, the third one is the previous cystectomy group, and they recruit the prospective current cystectomy group in group 4, whereby the AMH level was done before and 3 months after the surgery. So in the control group, as we know, there is significant higher of AMH level as compared to the endometrioma group and previous cystectomy group in all subtype of age. And you can see that the previous cystectomy is lower than the endometrioma group. And when we see that when they measure the mean serum MH level, also significantly lower in bilateral endometrioma compared to the unilateral endometrioma, as well as the previous bilateral cystectomy is lower MH as compared to unilateral cystectomy, which is statistically significant. And the group 4, whereby they do a prospective study 3 months before and after, the MH level was significantly decreased after 3 months or post-operatively. That actually conclude that actually laparoscopic cystectomy for endometrioma do lead to the reduced MH level. So therefore, as we know that when we're dealing with endometriosis, there are two pathologies that are related to reproductive. One is the endometrioma, which is chocolate cyst, and the deep inflammatory endometriosis, which is DIE. So for the endometrioma, before we plan or postulate the treatment for endometrioma, we need to know what is the pathophysio or mechanism or fundamental behind the propagation of the disease. The Hudson theory, which been postulated in 10 years from ago, has said that there is actually result from invagination of the endometrial tissue into the ovarian cortex. The endometrial metaplasia theory also supported the pathophysiology endometrioma, thus show that the endometrioma don't actually have the proper cyst wall, and when we do a cystectomy or evisceration, we actually strip the normal ovarian cortex rather than the pathology itself. So in regard of this lecture, the fertility preservation surgery that I would like to discuss lies about 4 of this technique. One is the laparoscopic management of endometrioma using the combination technique of excision and ablation surgery. The second is the 3-step technique that already been established quite some time, as well as the auto-transplantation of fresh human ovarian tissue in endometrial patient, and cryopreservation of ovarian tissue and transplantation for future fertility use. So the first technique that we combine the excision and ablation is actually the removal of endometrioma wall and ablative surgery that entails the opening of endometrioma, and we need to destroy the internal cyst wall by laser vaporization or by bipolar coagulation. However, the risk here is the excessive surgery when we disrupt the normal ovarian cortex together with endometrioma and leads to incomplete surgery that does lead to the earlier recurrence. So in this combination surgery has been proposed by Professor Doni and friend, they actually combine the partial cystectomy as well as the vaporization or ablation. So in this surgery, the last part of the endometrioma is first excised according to the cystectomy technique, as well as the endometriosis was opened and washed out with irrigation fluid. After we identify the correct plane, and then we will actually do a traction and counter traction using the two graft forceps provide a strong but non-traumatic force in inner layer in order to strip off the endometrioma layer from the normal ovarian tissue. But when we approach the hilus, whereby we need to very be careful of the bleeding, then we need to do excise the tissue with scissors. This stripping technique actually allow us to actually remove at least 80 to 90% of the cyst. However, if we provoke the bleeding, means that the plane is not clear. Therefore, we need to stop from there and start to do an ablation in order to reduce the risk of stripping the normal tissue. And the first step, which is the partial cystectomy, and compare and added it with the ablation, we actually can help to improve the excision as well as reduce the recurrence in future. So Professor Donias already published this technique in Frontier of Biomedical, and they noted that from this patient who underwent this combined technique, the AFC count was noted to be similar in women with control without endometriosis after 6 months of the surgery. Therefore, they propose that this can be the one of the best fertility preservation surgery for the patient with endometriosis. The second technique is the 3-step technique. Some people are not familiar, some people are familiar. As a reproductive specialist, most of my patients is using this technique. This technique was actually proposed in 1996 by Professor Donis and friend, because Professor Donis is very much well known as fertility preservation in benign as well as cancer patient. So the 3-step technique is the laparoscopic or transvaginal echo-guided drainage of endometriosis, and then after the drainage, they will suppress the endometriosis woman mesocycle 3 months with generation analog, and they will do a second look for resection or ablation of the remnant of endometriosis. By this surgery or by this technique, actually we can reduce the extensiveness of the surgery by 50% at the second stage of procedure. So this is what we do. We do an aspiration, and we do some sort of like aspiration from laparoscopically, and we give a generation analog, and we do a second look of the laparoscopic to see the remnant of endometrium that we can do ablation, or we can do a cystectomy that reduce the extensiveness of the first surgery. So the publication of this technique have been done in Human Reproductive in 1990, whereby they described this technique in 814 patients using this the 3-step technique, and they noted that cumulative pregnancy was 50% after first year, and recurrent rate was 8% after they follow up this patient for more than 2 to 11 years. So the laparoscopy of first look and second look also show the significant reduction of the scoring in terms of total implant and addition of the endometriosis scoring, as well as cyst diameter. They also noted that histologically, the active endometriosis also markedly reduced by 50% from 84% to 40% after the second look histological assessment. The third is the transplantation of fresh human ovarian tissue in endometrial patient. This fertility preservation technique can be used to preserve the ovarian tissue in case of severe or recurrent ovarian endometriosis where the normal residual ovarian tissue is compromised. The fresh cortex can be topically transplanted to the heterolateral ovary following the technique. One, we can identify the normal residual cortex dissect from the endometriotic tissue or in the peritoneal cavity, and we need to remove as much as possible to ensure the cortex viability before we implant it. And we can search for the anti-hilar region of the contralateral ovary and open it, and we put the fresh ovarian tissue there in order to increase the follicular ovarian reserve as create a new vascularization for a good implant. So this technique also been published in 2005 by Professor Donias and team, whereby the 2 cases of orthotopic transplant have been done for the 2 cases of severe and left large unilateral endometrioma. In the laparoscopy, the team noted there is a left ovarian vascular compromise, thus they proceed with left oophorectomy, and then they perform right orthotopic transplantation, and they did a second look and they see that microscopically there is a viable looking of the ovarian tissue following the second look of laparoscopy. So this is what they did when they see there is a very compromised vessel in the left ovarian. Then they did oophorectomy and do a cortex removal from the ovarian tissue that they removed, and they did some digging at the perihilar region at the contralateral side, and they put the healthy normal ovarian tissue there. And after the second look, they can see that there is a good viable looking ovary at the area of grafting, and they did a biopsy and noted from the fluorescent imaging, there is a form of the viable premedo follicle that suggestive that the fresh tissue ovarian transplant can be done for the patient with endometrioma. The last technique, which is the cryopreservation of ovarian tissue and transplantation. So this is a current emerging technique that fertility preservation can be actually advocate rather than cancer patient, for a patient who actually at risk for future fertility impairment. The embryo cryopreservation, oocyte cryopreservation, and ovarian cryopreservation can be offered depending on various parameters and type of the pathology, patient age, and also partner status. The only established method at this moment is embryo cryopreservation according to the ASRM, and it's very effective method. However, the patient need to have a partner. The cryopreservation of oocyte and freezing of immature and mature oocyte is continuing to be a breakthrough finding in current trending of reproductive field, and is provide a promising development in our field. So the ovarian tissue preservation can be done as a treatment of endometriosis in patients with impaired future fertility. The tissue biopsy can be taken during the gynecological procedure by laparoscopic or laparotomy, and may be proposed to 1 or 2 or 3 cortical fragment and cryopreserve. The number of biopsy is depending on the size of the normal healthy tissue that you can obtain from the operation from the endometrioma, and we can store it for future transplantation. This is the procedure that we do for our onco-fertility patient, whereby we do an unilateral oophorectomy. We prepare for the cortical tissue stripping, and we do a cortical tissue cryopreservation, and we thaw and we transplant later when patient need for fertility treatment. In Malaysia, our OTC already started in my center, which is an Advanced Reproductive Center HCTM UKM, where we already initiate in August 2020 for onco-fertility service for cancer patient, and we use vitrification method that I learned from Japan under the Kitazato company. We use a closed device as well as Kitazato media. Now I start a collaboration with the private sector with Sanford International Fertility Center to enhance the OTC under the cryopreservation unit in order to cater for the benign diseases that actually can help in giving them a future fertility. So our aim is to provide an ovarian tissue cryopreservation for benign and malignant cases to cater the fertility issue in women that have future risk of POI or cancer cases. So in Malaysia, what we do is we do ovarian tissue cryopreservation using the Kitazato method, and I use these titanium-based devices, closed device that actually good in order to reduce the contamination, easy to handle, and this technique is very much easier and can be implemented in Malaysia because all of our reproductive center currently is swapped from the slow freezing to vitrification. So this is one of the good invention for fertility preservation in endometriosis patient. A little bit about DIE. DIE is a deep infiltration when lesion is infiltrated into the subperitoneal space beyond 5 mm. Appeared to be a deep subperitoneal nodule and have predominantly fibromuscular component that proportionally greater than the endometrial gland component. Usually this DIE will behave like benign tumor. They can infiltrate different pelvic elements such as uterosacral ligament, lower hypoglycemic neural plexus, sacral vagina, rectum, and etc. Apart from this symptom of infiltration, we can see that our endometriosis patient have consequences such as bowel obstruction, asymptomatic hydronephrosis that can lead to progressive renal atrophy. So it's very important for us to know how to do the surgery for DIE or refer to somebody expert like Dr. Selva. So as we know that there's a lot of studies show that when you have DIE before the fertility treatment, a lot of people try to convince that after we do a good surgery for DIE, they can actually improve in fertility outcome. So this is one paper that I can share with you with interest of time. The fertility before and after surgery in DIE with or without bowel involvement. They noted that in this paper, they actually do some sort of like midline search for the literature review from 1990 to April 2013 in order to see whether DIE with or without bowel involvement have a benefit of surgery pre and post operation. And they noted that in 1,295 cases of the patient improved the pregnancy rate after the operation. Thus, they conclude that in patient with DIE, usually we need to actually do a good proper surgery prior to embark into the fertility journey. However, if you see the Ayrshire recommendation at this point, they noted that a woman who infertile with DIE, they cannot find any study that have high level of evidence to recommend surgery for deep inflammatory lesion prior to management of ART in order to improve the fertility outcome. However, we know that this kind of patient do suffer with pain and some sort of like symptom and sign that cause obstruction that warrant surgical treatment. Therefore, we can do an excision of DIE prior to ART in order to improve this. But for fertility treatment, is still unconclusive. So before I end my lecture, this is the recommendation for the fertility preservation in endometriosis, whereby in pre-op assessment of endometrioma patient desire fertility, we need to see whether it's bilateral, unilateral, pre or post cystectomy, or history of multiple surgery. And we need to do an ovarian reserve in order to classify whether the patient needs for fertility preservation prior to the second or repeated surgery. If a normal patient with normal AMH, then you can actually propose for the technique that I have mentioned before. Or if low ovarian reserve, I think you should consider fertility preservation technique, whereby oocyte umbilical preservation or ovarian tissue cryopreservation prior to the propose for the next surgery. So in conclusion, the pathogenesis of endometriosis and its surgical treatment both contribute to decreased ovarian reserve. Optimization and preservation fertility in women with endometriosis begin with preventing iatrogenic injury. Surgery must be performed judiciously with attention to possible of damage to the ovarian reserve. Fertility preservation with oocyte or ovarian tissue cryopreservation should be considered on an individual basis for women with endometriosis. With that, thank you.
Thank you, Dr. Mohammed Faisal. That was a very nice lecture, nicely put. One question, okay, what category of patients would you consider as low ovarian reserve? What would your AMH cutoff be?
Okay, usually if we have a patient, it depends on pico or nanomole. In my reproductive practice, usually I will take it less than 5, is considered low MH level that I will actually propose for fertility preservation before I embark to another repeat surgery.
Right. Okay, I think that's about it. Thank you for a wonderful lecture. It was good having you on board, and thank you once again. Now we go on to the next speaker. We have Dr. Chu Kim San. He is a reproductive medicine specialist and a laparoscopic surgeon. He is based in Metro IVF at Metro IVF in Malacca. Now, let me go through his CV. He has done his subspecialty in reproductive medicine. He also did his fellowship in minimal invasive access surgery, which was in India. Then continued in Singapore. Then he did his IVF training in Singapore. He has worked in many hospitals, and currently he is attached at Metro IVF. We have Dr. Chu. He will be speaking to us on surgical management of hydrosulfanes in infertility. Dr. Chu.
Okay, thank you, Dr. Kanapan, for the kind invitations. Thank you, MSAT, for the invitation to give this for the introduction. Let us see. Okay, sorry. Today I'm going to, can you see the slide? Sorry.
Yes, we can.
Okay. Okay. So today I'm going to talk about surgical management of hydrosulfane in infertility. I'm going to talk about the practical aspect of it, as well as more of the evidence approach rather than the technical part. I've been trained in both the minimal invasive surgery as well as reproductive medicine. So I'm going to incorporate the evidence part, evidence-based part of it, and a bit of trick and tips from my reproductive medicine surgeon mentor who guided this. So first of all, I probably moving my slide. Oops. Sorry, the problem moving my slide. Sorry, can I just short share one? Sorry, I share again. I have problem moving my slide. Hmm.
Sunny, could you guide Dr. Chu, please? Yes, we can see your slides.
Sorry. Okay, great. Okay, thanks. Sorry for the interruption. I have no financial disclosure for this lecture, not paid by any of instrument company. Is from National University Singapore, KK Women Children IVF Center, as well as MIS Center, as well as some of my reproductive surgery mentor, Professor Samantha Pfeiffer from New York, from York 5 Singapore, and from Sydney, as well as Professor Charles Gore, DC. So what is the overall scope of my talk is today is that I would like to explain what's the impact of tubal factor infertility on IVF outcome and how does various step of this pathology differs and impact on different fertility treatment. And would like to also, is there any indication for surgical treatment before IVF treatment? Then any differences of different type of surgical approach, whether laparoscopically or hysteroscopically, in actually alter different outcome? And then also in the context of whether should we do surgery first or should we do IVF first? And if let's say we do reconstructive surgery first, followed by IVF, would there be any difference in all this? So I will explain in nutshells in the next 20 minutes. So first of all, we know that actually tubal factor actually contribute to 35% of the cases of female fertility. And we know that from infertile female population, 30% of them have actually hydrosalpinges, actually demonstrated by either HSG or actually laparoscopy. And we know that from publications that hydrosalpinges actually reduces the pregnancy rate as well as live birth rate by actually 50% for those undergoing IVF treatment. And the most notorious risk factor actually we notice is most probably from infection, usually chlamydia, trachomatis, as well as Neisseria gonorrhea, as well as Southern Asian group, like those with tuberculosis group. Rarely is actually more common is those with associated with endometriosis changes, which I'm not going to touch a lot on this lecture. And I'm going to highlight a lot on chlamydia today because that is the things that I think a lot of idea that I need to emphasize on. What will happen is that when you have a constant exposure to chlamydia through the genital tract, and this will lead to a lot of heat shock protein generation. And what does heat protein generation? You can see a lot of this. This is the liver. Okay? This is the over the diameter, and you need this violin strain, and this is the evidence of this heat stroke protein generation. And what does this heat stroke protein generation happen is it causes internal inflammation reaction and led to a lot of immune response to it. And what does this mean is that it leads to tissue scarring, either to the endometrium as in tubal damage. Okay, so therefore, when you categorize hydrosalpinge caused by chlamydia, they have actually a different degree of severity as compared to other diseases. How does this sit? We'll talk about pathophysiology. So what happens when you have a chlamydia, when actually you actually activate or affect the cystic fibrosis transmembrane conductase regulators. And when this thing happens, is what will happen is that the calcium channel block ion block regulator will get altered. So this leads to a lot of secretion of this fluid in the oviductus, where else they decrease fluid absorption. And the same pathway actually it generates also is a lot of tissue scarring, especially towards the fimbriate end. And this ultimately ongoing infection, constant infection will lead to occlusion of the tissue. And this do actually generate into fluid accumulation and ultimately cause the formation of hydrosulfide. Therefore, when you have a hydrosulfide, there has been long years or even months that this thing has going into generate all these cystic fibrosis regulators. And how does this diagram actually show that? How does this chlamydia trachomatis, how does it infect a woman to go into a very severe form of infertility problem? So we categorize them into 4 categories. Actually infection actually activates cystic fibrosis regulator, and it actually alter the volume regulation inside the oviductus fluid. The pH control, the pH have been altered, and then the bicarbonate transport. Therefore, it's postulate that those people with actually mild or actually moderate hydrosulfide, they have actually poorer embryo development as well as this because of pH as well as sodium, all these ion changes. The second thing is that when this thing is generated, especially with the calcium ion actually altered, it actually generate a lot of hydrosulfides throughout. Initially start from the ampullar region and it expand to the whole length of it. And third thing is that how does chlamydia affect its generate a lot of heat stroke protein as well as protein production? Ultimately, it affects the endometrium area. And therefore, when you do a histoscopy component with someone with hydrosulfide, often you're going to see a lot of even 50% correlation that you see a lot of this micropolyp formation as well as interstitial edema happen. And the fourth thing is that chronic inflammation tissue alter the immune response so that the immune system actually start to attack the oviductus tissue and causes scarring, inflammation, and ultimately lead to actually complete obstruction. So in these 4 pathways, this chlamydia has effect. So therefore, chlamydia have a more severe consequences as compared to other organisms that are going to affect women. So 2017, actually, we have actually publications that most of all the ovarian cancer originate from fallopian tube. And we know that actually ovarian cancer actually originate from the fallopian tube epithelium rather from the ovarian surface epithelium. So that the seedings actually coming from actually tubular epithelium, they go all to the ovary as short as 6 to 7 years. And now the postulation is that, is this all this damaged fallopian tube causing hydrosulfide at an accelerated rate, maybe shorter than 6 years in going to ovary? Nobody knows at this moment. Therefore, we have to have a paradigm shift in how we're going to treat hydrosulfides in the term of future development of epithelial ovarian cancers. And this is the most important slide that I think to highlight is that there are stages of how the fallopian tube destruction happen. The first will be when the organism of especially this chlamydia go in, they will first alter tubal mucosa, especially the columnar cell. When the columnar cell get affected, the nutrients that providing to the fertilization as well as to the transport of maturation or migration of the embryo towards the embryo, it get affected as well as they affect the ciliary movement as well. This is the first stage. The second stage is that the infection actually go into affect the calcium ion regulator, and this lead to a lot of fluid circulation, decrease absorption, and therefore we start to see hydrosulfides emerges during this, especially during HSC. And the third stage is that when this infection is persistent going on and the whole tube has actually been affected, then the inflammation, the scarring, and the fibrosis start to affect the fimbriate end. And therefore, from there onwards, we will see the complete dilated tube. So therefore, what do I have to tell this is these 3 stages is most often when you do HSG over here, you actually pick up all this. But if the HSG is normal, are you excluding that this tube is completely normal? No. The problem is you have actually a hydrosulfide actually the ion channel as well as the stuff really long being affected. So this actually has led to tubal dysfunction at this stage. But how accuracy is our today's, most of our assessment actually were done by actually HSG as well as laparoscopy. And you know that this tubal pathology at this stage is fully picked up by this. So I would like to say that actually this is actually a tips of the iceberg concept, that when we see actually a dilated tube over HSG, are we good enough to say we proceed with just use the other tube and just ignore the tube that happens with it? Would it be good evidence to say that this should be adopted? The answer, I think, in 2021, I would say is that's a no. Because when you have this, you do not know what's the multifactorial organs that affected it. When you do a scope, you often see that the tube is dilated, is part of it, and there's a lot of excisions that ahead from bowel all the way to uterus. And this one all affect your fertility, especially they will dissociate synergistic or logistic between the fimbriae and the fig. The second thing is that etiology. Then you look at the livers, you found this. This is called the fistulus curtis, which pathognomonic for chlamydia and Neisseria. And this one actually have a very nasty effect, destruction of the tubal mucosas. And also when you do histoscopy, over here is that you see a lot of micropolyp formation here, as well. This is micropolyps all over, as well as interstitious edema over the surrounding. So means that the hydrosulfing has convert a tubal factor into an implantation factor. And when this is a test that we're going to describe, I'm going to elaborate further, is this is a sulfingoscopy in which we put in a histoscope through the fimbriae end and bypass it through into the ampulla region of this. And from this area, you can see that a lot of scarring tissue, a lot of fibrosis, a very pale looking tissue, which is not healthy. So therefore, when you have actually a dilated tube or hydrosulfing or even a blocked tube on HSG, this should be just a tip of the iceberg that you should trigger your alarm and do further elaborate, because the end point of this hydrosulfing just is the patient would like to know what will be my best treatment for me. Secondly, what will be the success rate if I undergo either IUI, IVF or whatever. What are my risks of getting ectopic pregnancy, and what are my risks of getting miscarriages? When we noted that those patients have actually undergone sulfingectomy for hydrosulfingers, we know that the endometrial luminal epithelial, endometrial receptivity, alpha 5 and beta 3 expression will be increased for the next 3 months. From this graph, you noted that. So therefore, we know that there's actually, in most of the cases, the tubal epithelium affect whatever things that is going to happen in uterine character. So that is actually quite a 90% correlation that sulfingectomy has actually influenced, improved the endometrial receptivity. And today I'm going to describe mainly only three laparoscopic procedure. Laparoscopic sulfinject means completely removal, tubal occlusion maybe at the proximal part, and sulfingostomy where actually you have a reconstructive surgery over the fimbriae end. Okay, and also one histoscopic tubal occlusion which is actual. Okay, and the other two ultrasound guided expression as stereotherapy I will not discuss because there's a lead to high recurrence rate of hydrosulfing, so therefore is not very relevant in today's practice. How do I consider, because you have various level of training of people who practice IVF here with different degree of surgical training. So how do I divide into these three approaches? That the first group of people, if you see hydrosulfings, you'll do expectant management and proceed with IVF treatment. And only you consider laparoscopic surgery only after three unsuccessful with actually 3 embryo transfer. Okay, that is option number 1. Option number 2 is that you do sulfingectomy for all cases of hydrosulfingers. Number 3 is that you go and do a diagnostic laparoscopy and you divide your tubal pathology through the sulfingoscopy approach into good prognosis as well as bad prognosis. And in the group of good prognosis, in an isolated tubal factor, you try to do sulfingostomy. Okay, where else you encounter our pathology that is not good prognosis, okay, you revert back them to self-injectomy. So group A, B, and C. And we know that from actually compare self-injectomy versus no surgery, what ratio is actually of getting live birth is 2.13. As this study meta-analysis showing that looking at live birth across all meta-analysis, it showed that 2.13 actually odd ratio. Even some of the meta-analysis go up to 4.3. Therefore, when you want to reassure patient when you have hydrosalpinges, you have to take a word of caution because the data is actually against you. Okay, and how the thing is that when you do constitution, patient would like to ask, I have so much varies of option A, B, and C. How do I actually come into cost effectiveness analysis, especially for the health economists? So you have to look at that at actually 5 factors. The first is actually the initial treatment cost. Let's say it's either IVF or it could be laparoscopic surgery or cystoscopic surgery. And you have to look at the success rate of even different options that you're looking at it. And also 3 is that the inconvenience, like time taken for you to achieve live birth, is it first attempt or is it across 1 year, 2 years, or 3 years? And also the most important point is that after you do the initial intervention or initial treatment, any subsequent consideration that you have to face, like you have to handle ectopic pregnancy and miscarriages, because that lead to time delay as well as a cost for the additional procedure before you really achieve your live birth. And also the persons who actually, the doctor who treating you, what is the skill and ability actually in doing this surgical treatment, because this surgical different surgery come with different requirement for skill. And we know that from meta-analysis, self-injectomy with no surgery in terms of live birth actually is double. And when we look at cost effectiveness, comparing those 5 factors which I mentioned earlier, we know that self-injectomy has more cost effective. This is by the Strando group, okay, which actually demonstrate that if you actually do self-injectomy first, then you follow by IVF, compared to you do IVF and then you encounter, let's say then if you do surgery later or this one, how does it compare? It's actually, you have a more cost saving in terms of self-injectomy, 10% as compared to no self-injectomy. And people were always concerned, if I do self-injectomy, how is my ovarian output? This is actually a data actually come from Strando, from a well-trained reproductive surgeons center, which they do a lot of procedures. So what they're going to see is that the dosage of FSH, the duration of stimulation, the number of retrieved oocytes and fertilized oocytes does not differ between this group. Therefore, they conclude in well-trained surgeon, appropriate management of surgical self-injectomy does not actually differ a lot in terms of ovarian stimulation outcome later on. But word of caution in anatomy is that there's 2 areas that you have to be very cautious for actually those people who actually start new, is that there's the first 2 centimeters from the cornu end, there's a vessel of anastomosis between the mesosalpinx vessel as well as the proper ovarian ligament. So when you want to approach this, preferably if you're a new starter in the laparoscopy, so in this is that you try to separate this and try to use advanced bipolar in the coordinates so that you try to minimize your thermal injury to these ovarian parts. As well as when you read over here is that when you have a vessel curve from mesosalpinx all the way down, try to take it as high as this level, never to take it at the level of infratubular pelvic, because it will actually compromise the distal half actually of the ovarian volume. Okay, so how does we compare people who like the self-injectomy versus non-self-inject like self-ingostomy? How does it outcome in terms of stimulation days, gonadotropin users, quality oocyte, number of qualities? It doesn't differ much. And when we want to look at this self-injectomy done, when you do occlusions for self-inject, most of it actually in the range of 20 to 30%. Okay, so therefore it's actually is either occlusion is as good as actually self-injectomy. And I will emphasize a lot on salpingostomy today is that it's actually due to reconstructive surgery for the fallopian tube. So what I'm going to do is that the most important factor is your patient selection. You select the wrong patient, you offer patient salpingostomy, you lead to a very poor outcome. And what are the things that you want to look at is you have to look at the mucosa level, the mucosa appearance. You cannot assess the mucosa appearance of the hydrosalping by looking from laparoscopic view only. You have to go inside the fallopian tube and going through here, and then you visualize the tubal mucosa in it. And that is the most important factors that decide whether your salpingostomy or reconstructive surgery going to make a success. And other factors like the size of hydrosalping, the peritubular excisions, as well as either these fimbriae end has been occluded. That also play actually important factors. And when you do a patient selection and you do appropriate surgery, you can result in 27% normal pregnancy, as well as 25% live birth rate. Means that the conversion from pregnancy to live birth, you do not lose a lot through ectopic as well as miscarriages. But you have to bear in mind is that you still have a 10% risk of ectopic pregnancy after even you select the most appropriate patient and most appropriate surgery, as well as 7% of miscarriage rate. It's this has been a bit higher than the salpingectomy group. Okay, and how do you counsel your patient after this? Important point is those people who pro prognosis factor, you try to discourage them for salpingostomy, even though they do not want salpingectomy. What are the risk factors that you know that is going to give you pro prognosis? One is that they have undergo previous salpingostomy before, and then they have previous ectopic, they have very bad adhesion, and the most important point here is those with positive chlamydia serology or those people with Fish-Hughes Curtis that you see on laparoscope, try not to offer them tubal reconstructive surgery because the recurrent rate is high and the ectopic is very high. So therefore, these are the group that you have to identify and counsel appropriately. And also the other second thing when you do counseling for this is when you do salpingostomy for this patient, you have to wait for 1 year to see the 20% effect. Not like I do it immediately, but in the next 1 or 3 months, unlike the IVF treatment, you'll get the babies within 1 to 2 months later. But you have to be patient actually to look at for 12 months, you actually get almost a 20% actually pregnancy rate. It's not live birth, it's a pregnancy rate. You drag on into another 24 months, which is another 1 more year, you only get additional 5%. So therefore, you have to tell the patient between your waiting time is between 12 to 24 months of waiting for this. And we want to see whether there's 2 groups that when you have a hydrosalpingia, should you do immediate IVF? Actually lead to a live birth. And the second group is that maybe you offer them reconstructive surgery or do tubal occlusion while waiting for, and only do IVF 1 year later. But at the end of the day, at the end of 24 months time, actually the catch up point, the delay IVF group actually had managed to catch up with this. So therefore, when you have this pathology, if due to financial constraint or you have a waiting this long, maybe try to offer them some sort of surgical intervention within this 1 year before I embark on this. And you are actually not left behind from this. And the other part is actually going to save us is about Assure. It's actually a cystoscopic occlusion of the hydrosalpinges. And actually the evidence actually from this trial has been lacking and has it now out of favor. And I'm going to explain to you why. Because this the meta-analysis of all this is that when you look at live birth rate comparing no intervention, Assure, and laparoscopic surgery in terms of salpingectomy or tubal occlusion, this consists of 33% success rate. And this is only 11. And this is somewhere in between 24%. So therefore, we can conclude 3 good conclusions from this is that when you have saw the patient with actually bilateral hydrosalpinges, please do not reassure them, okay? Then maybe most probably is that you have to tell them this is the gold standard, but in the events that you cannot offer them the laparoscopic surgery because of whatever reason, they cannot go for GA, they are not fit for laparoscopy, maybe Assure is much better than no intervention, okay? This is how we're going to do laparoscopic salpingo because this is not, I'm actually running out of time. So this is what I use is actually a 2.9 mm of hysteroscope, and I insert it through actually the lateral port of this. So you have to have two systems. One is for your laparoscopic system. Another one is through your salpingoscopy. So salpingoscopy is just like a hysteroscopic approach towards the fallopian tube. And what the prerequisite is that one of the forceps you have to hold onto this tissue, and you have to use it, this hysteroscope, you have to use to the vaginoscopic technique because you cannot use dilatation. So you have to adjust your anatomy. And this is the area that we got to visualize is only the ampulla region. This region, because ampulla region are the most dilated region, have lower risk of perforation if let's say this thing happen, and this is the common site of fertilization happen. And what will be the outcome of this is that this is the normal appearance, multiple 3 to 4 mucosa fold, and very healthy looking. And when you start to have infection, you can see that the mucosa fold has been fused, and you don't see the mucosa fold very well. And this is some of the things that ensure ongoing infection. And this is actually a fibrous spread. And how does this is actually a very long-standing treatment. You can see the overall the mucosa area become very pale, a lot of scar tissue, a lot of fibrous tissue. And this one, if you're the greatest surgeon on earth, and if you go and do surgery, we concentrate surgery on this, you'll end up with ectopic pregnancy. Therefore, you have to identify these are the group of patients who are not suitable for you to offer reconstructive surgery for this patient. You have to offer salpingectomy for this group. And also, when you do laparoscopy, you have to take other consideration that will actually outcome, because the ultimate gain of this is live birth. Physiotherapists, you say this, do not offer them reconstructive surgery, salpingectomy. Okay, as well as hysteroscopic, when you look at this, is that this is strawberry cervix, hyperemia, as well as this is the diffuse micropolypsis. This is like this is a very toxic fluid because of the heat stroke protein generation from the tubule will affect this. Okay, and this is actually the stroma edema happens from this, as well as a lot of this. And usually I will say that all this actually come in combination. Why did I say that? Is that this is actually the overall, if you want factors present, around 50% incident of chronic endometritis. But you have a combination, you will range from as high as 60 to 80% of it. So therefore, when you have a chronic endometritis, you are uncertain about this, it's better to not offer them reconstructive surgery, offer them salpingectomy. So, sorry, and because how do I approach this? Yes.
Thank you. Sorry.
Yes, summarize this is a summary. Okay, so age factor as well as good or poor lesion. So if you have a someone who is less than 37 years old, you do salpingoscopy, you noted that this is a good prognosis, offer them reconstructive surgery because they have time actually within 1 year after we got 20% actually achieve a live birth, a pregnancy, and you maybe delay IVF after 1 year later. Secondly is actually those with young but bad prognosis. What you're going to do is you have to offer them IVF, and you have to remove whatever things like salpingectomy that to enhance your IVF result. What about the third group? Actually, you have older patients, but they have good prognosis to both. Okay, what you should have to offer is that you offer them reconstructive surgery, as well as you offer them immediate because of their age factor. Because you also, they want to conceive on their own if let's say they have actually their tubal problem do not progress in worsening condition. Age 37, when they have bad tubes and they are old, offer them IVF and clear whatever that's necessary. So the last slide is the distal conclusion. Distal tubal occlusion actually had a tremendous effect on decreased pregnancy by 40%. Hydrosalpinges, surgical treatment actually restore the chance of achieving a pregnancy, and laparoscopic approach in terms of salpingectomy and proximal tubal ligation have the same result, almost as high as 30 to 40%. Astro is more effective, but it's not as popular now, but it's much better than compared to no intervention at all. And to this, but we have to counsel this patient is that it's less effective than all laparoscopic options that we have today. So we all thank you, sorry for crossing the time.
Thank you, Dr. Chu. There was a wonderful lecture and you had given us quite a lot of details. Actually, there are quite a number of questions, but I think we will forward that to you for you to answer, and it will be coming out in the WhatsApp group. All right. With this, I'm coming to an end of the session. Thank you, Dr. Chu. Thank you once
Thank you
again.
very much,
And
Dr.
coming to an
Kanapal.
end of the session. We had a wonderful day with all the laparoscopy surgeons. Now I'll be passing on to Dr. Navdeep to continue with the program itself. Dr. Navdeep, thank you.